So
Thank
we'll
you,
move
Raj.
forward, and we got next set of chairperson with us. May I please first invite Dr. Ajit B. Maji, Center of Sight from Hyderabad. Hello, sir. Very good afternoon. Uh, Followed by a co-chairperson, Dr. Vishali Gupta, Advanced Eye Center PGI MER from Chandigarh. Hello, doctor. I don't. And then our moderator, Dr. Anand Vinekar, Narayan Netrale Eye Institute, Bangalore. Yes, Dr. Anand, I and chairperson, I hand it over to you. We got 6 speakers. They'll be using 12 minutes to talk, and we'll do all the Q&A at the end. Yeah, thank you.
Thank you. Thank you, Mr. Raj. And on behalf of all the chairperson and all the speakers, welcome to this Retina on Fast Forward. It is going to be a fast forward because we have great talks and a limited amount of time. So I think let's move on directly to our first speaker, Dr. Vishali Gupta, who doesn't need any introduction. Madam has been my teacher at PGI and a world-renowned authority in not just retina and uveitis, but also in her niche area of imaging. And that's exactly what she's going to talk to us about today, advances in retinal imaging. Dr. Vishali, over to you, please.
Thank you, Anand. It's always a pleasure seeing you, meeting you, and thank you, Santosh and Telangana Ophthalmological Society, Dr. Ajit Babu, for giving me the opportunity. The topic is fast forward retina, and I'm supposed to be talking on advances in retinal imaging. If you ask me, there are lots of imaging starting with fluorescein, wide field, ultra wide field, OCT, NGOCT, then we have PAN, adaptive optics, so on, and you can keep on naming them. Personally, I'm looking forward to molecular imaging that would integrate the anatomy with your functional. But what I'm going to talk about is actually totally off the track. In the era of multimodal imaging, there are several imaging modalities available. And simply because we have added a new toy to our hospital, should we start getting it done from every patient? Or should we learn to customize imaging based on patients' needs? So I think we need to fast forward, but not in technology, actually in our intellect and for the judicial use of that technology. So let's look at the retinal diseases and the concept of customized imaging in retina. So it's very important that you look at the phenotype. You look at what are the structures involved. Is it retina, choroid, retinal vessels? And you should ask yourself a question. What is the information that is being sought from the imaging? And what is the question, a particular question that needs to be answered? And how this imaging is going to help me in decision making. Like, does this imaging have any translational value? Or is it just overloading you with the kind of the information that you do not understand and it confuses you? So hence comes the concept of customizing and ordering the need-based images and interpreting them in the right context. I will show you a couple of examples why you need to customize. Now we all know we are moving in the era of confocal scanning, laser ophthalmoscope imaging, and you will, I'm sure we and most of the centers are getting away from the true color imaging because most of the machines and very expensive one now have pseudo color or multicolor confocal scanning images. And then we have multicolor imaging, we have infrared, we have green, we have blue. And you know, all of us are talking in conferences about the advantages of each of these modalities. Now, you are all experts sitting there. Look at these images. What do you think? Though I have highlighted the area of interest, but still I would just say, probably to me, it looks normal. And then you see the true color picture. There is a huge choroidal, not a huge, but there is a distinct choroidal granuloma, which is sitting there, which you can see so beautifully on color fundus picture. And actually you miss out on the nubula. uveitis. Again, the autofluorescence also shows it. Another example, we have this patient which has serpiginous-like choroiditis. You see this one is inactive, but when you look at the MCI, the multicolor imaging, does it look active to you? The edge? To me, after so much of years of uveitis, to me it doesn't look active, or at least I'm not able to differentiate. But when you look at the color picture, you see it so beautifully. This is the healed and this is active. And similarly, you miss out on all the imaging modalities which come with scanning laser ophthalmoscope. So the moral of this story is we are coming up with this publication soon, but the lesions of active posterior uveitis were very poorly identified on MCI. So if you think you have got a new expensive tool that you're going to use in all the conditions, probably you are going to miss a lot on active inflammations. Then how do you customize? Once we know that it has to be need-based, how do you customize? There are three things which you should ask. Is the imaging helping me either the disease prognostication, or pathogenesis, or etiology? So let's see this patient who has CSME and who has a vision of 2400. And for me, the basic reason here is to find out why is the vision low. Now, what could be the common causes? It could be drill, which is morphological, or it could be foveal ischemia, which is functional. So what do I need? If I do the fluorescein, it is not going to detect drill. It may tell you ischemia, but still I will miss out on drill. Same is with the wide field fluorescein. OCT will help me detect drill, but probably not ischemia, and OCT angio ischemia, but not drill. And rest of the imaging, including autofluorescence, ICGs, are not going to help me. So what do? I do non-invasive investigations like OCT, which shows me there is disorganization of the inner layers. And this is just the magnified view to show it. So now I know that it is the drill which is corresponding to the poor visual loss, and probably I don't need to do all the multimodal images in this patient. Another case scenario, type 2 diabetic, and patient is not responding to treatment, 8 injections of anti-VEGF, and I want to know why is it not responding. So my first choice will be OCT, because fluorescein is not really going to tell me, and OCT shows me there are hyperreflective dots, there is SSRD, which are actually the biomarkers of inflammation rather than VEGF response. So I know that this is the patient that might respond to intravitreal steroids rather than anti-VEGF. So this imaging helps me straight away in decision making. Or your imaging should help you in describing the etiopathogenesis of the disease. For example, on the top, you see a patient. This patient was seen 2 years ago by a neuro-ophthalmologist who diagnosed his idiopathic intracranial hypertension because his CSF pressure was high. He was treated with Diamox, to which the patient responded, the disc edema. But if you notice here, there was this pocket of serous fluid which was missed at that point of time. Now patient comes to us with increase in the serous fluid in the fovea and decreased vision in the right eye. So when we do the imaging here, this beautifully shows the gravitational tracts which correspond to what we see in chronic CSC. Now the question I asked myself, is it a patient that is having two diseases, IIH and CSR, or is there a correlate between the two diseases? So we do fluorescein, and fluorescein does show multiple pinpoint leakage points, which you expect in CSC. But when we do ICG, wide field ICG, here you can see the anastomotic channels which are drawn in yellow between the vortex veins. Now, these anastomostic channels actually are very interesting because they indicate that this is venous obstructive choroidopathy and not really CSE. And these arrows here indicate that there is also the retrograde flow of the blood towards the back of the eye. And when we do the MRI actually shows us that there is stenosis of transverse sinus, and we are reporting this as well, that these two are the diseases which belong to the same spectrum and not the opposite disease. And my third leg of the talk, which is the simplest, is that defining these imaging to pick up the etiologic diagnosis. For example, this patient was brought to me with fever, which was suspected to be dengue, and I looked at it, and my first thought was, oh, this is foveolitis due to dengue fever. But within 48 hours, you can see this classical sign. This is rain cloud sign. So if you have a rain cloud sign, it got to be fungus. It cannot be foveolitis. And you can see so beautifully now, it's an abscess and the fungus which is growing. So you don't need anything else. You have this sign which tells you it's fungus. Go ahead, do vitrectomy, whatever, and get over with it. Another young lady who was referred to me as a case of suspected retinal angiomas, and you see these dilated tortuous vessels running all over. And you could do anything with this patient, doing ICGs or fluoresceins or whatever, but a simple test is to look at the character of these tortuous. Yeah, I noticed. Tortuous vessels, and if you notice here, this is hyperreflectivity uniform. Normal vessels do not have this uniform hyperreflectivity, they have a figure of 8. This uniform hyperreflective means there is something going on in the blood, and that blood is chronic myeloid leukemia. So these are the signs which you should be looking for rather than keep on adding new things. Similarly, a lot of patients now we are seeing with serpiginous choroiditis, metamorphopsia, and you can use NGOCT very effectively to detect the underlying new vessels under the scars, which responds incidentally very well to anti-VEGF therapy. We have started doing more and more of angio-OCTs to look for areas of capillary non-perfusion and not even the leakage. Sometimes depending on the color coding of the vessels, you can actually make out that these vessels are likely leaking than not leaking. So, to me, the advancement in imaging is not just to keep on getting the technology, but to move fast forward intellectually and utilize that technology so that that technology does not become your master. Thank you very much once again, Dr. Babu, Santosh, and Telangana Ophthalmological Society for the kind opportunity.
Thank you, ma'am. And that was very, very comprehensive. And I think you brought out some very key learning aspects there on how to master technology and how not to get carried away with some very beautiful clinical illustrations. Since we are taking, I believe, the questions at the end then?
Yes, yeah,
Okay.
we'll take the Q at the end.
Okay. Will you be telling us questions that have been asked by delegates? Because we are not able to see them here.
I'll pick it up. I'll check with the system.
Great. Okay. So then in that case, let's move on to our next speaker. Dr. Kim Ramaswamy, again, needs no introduction. Sir is from the Arvind Eye Hospital group from Madurai. He's very well known to be a VR surgeon par excellence, and today he's going to talk to us about one more of his areas of interest that he's of recent done a lot of work in, especially in the Delhi Ophthalmology Society of India. Today he's going to talk to us about AI and ophthalmology, current status and future impact. Sir, over to you.
Thank you, Anand. Let me just share my slides. Can you see my slides?
Yeah.
Yes, doctor.
Yes.
On the full screen, right?
Yep.
Okay. Okay. At the outset, I want to thank Dr. Ajit Babu and Santosh for inviting me for this important forum. And my topic slightly after what Dr. Vishali was talking about, how technology is kind of becoming a master. There's another technology that kind of is playing a major role in what we are doing now. I'm sure all of us have seen or heard about self-driving cars, which we may see them soon on the road, or our regular day-to-day applications that we use, like the Google Photos, which can pick out all the photos that you want by just searching by names. All this uses AI. So what is this AI? It may be sorry if I'm too basic. Normally, a computer is programmed with a set of rules within which they function and produces the exact result. While that machine learning does is to teach computers to learn without having to program them with rules. Especially when you repeatedly expose a lot of examples to a system, it is able to learn from this data. Of course, artificial intelligence came as early as 1960, but then over a period of time, it lost and then again has gotten a lot of interest in the recent times, not only in healthcare, but in almost all fields of our life. And under artificial intelligence, there's a lot of sub groups which actually the way the algorithms work, like the machine learning, deep learning, or convoluted neural network and various other stuff. So today we have a lot of applications that we use in our computers, in our phone, almost every day. Without our knowledge, we are using these artificial intelligence-based apps. So what does it do to in medicine? The amount of data the human brain can analyze is limited by its capacity, while machines can crunch millions of data in few seconds. When huge data is available, it is easy for the machines to scan, analyze, and make interpretations much faster than what the human brains can do. So what can AI do for us? There are so many processes that we as doctors would be doing repetitively with little training. Anybody can be made to do that, such as grading a fundus images as in diabetic retinopathy. There are so many activities that happen in our day-to-day activity, which need not be done by, which may not be a good use of our time. So can AI do that? Yes, AI can be taught to learn and may do these repetitive tasks. More importantly, it can find new signals, which is finding out some things from the data that is there. As I said, the machines can crunch millions of data, which while the human brains can't do, and it is able to find out few new things based on the data it is given. So how can AI help? In many ways, in screening a disease. Today, it is helping in screening a disease. It can help in diagnosis. It can help in management of various diseases. The low-hanging fruit that was available for AI developers was screening for diabetic retinopathy. This seems to be the favorite of all the people who are working on artificial intelligence development, to find a right algorithm to identify or to read a fundus image. And this has become almost a real-time usage today. We have been doing this tele-screening for almost 20 years now, taking fundus pictures from a diabetic clinic and sending it to a reading center where the grader or a retina specialist grades the image and sends a report back to the diabetic clinic so that the diabetologist can refer the patient to the ophthalmologist. But today, the AI algorithm is doing that job. How is it? It's developed after it is being exposed to thousands of fundus images with various grades, and over a period of time, the system has learned to grade these images. This is one example where the AI tool analyzes a fundus image and within a few seconds is able to grade the image almost exactly like what ophthalmologist or grader can do. So what the grading does, it can give you a mild, moderate, or severity level of the diabetic retinopathy. We can add over that what should be done next to it, and then send the report back to the the diabetologist, who can advise the patient on follow-ups or review again. So today, this whole process, which took an hour or two, can be done within a minute without the time taken by a retina specialist or a trained grader. So over time, in many of the validation studies, it's been seen that the AI algorithm does much better than the grader or better than a general ophthalmologist, and it is almost comparable to a retina specialist. How it can help in diagnosis. Today, there are tools, of course, a lot of work is happening on detecting diabetic macular edema just using fundus photos with almost as accuracy of the OCT. I'm sure this will soon be available on almost every fundus images fitted with these algorithms, or even in management. It's able to predict the response to an anti-VEGF injection. Now you're giving an injection, it may be able to tell you how effective this injection could be based on the data or the past data. It is able to detect or give you advice on what should be done next. Also, it is able to see if an AMD patient who has signs of early AMD, would they develop a wet AMD in a period of 1 year or so. This has a tremendous potential in managing these patients or following up these patients. Same thing, just by looking at the fundus photo, the system is now able to predict what could be the refractive error of the fundus or the iris. Another important or interesting feature is this predicting the risk of developing a diabetic retinopathy. A diabetic patient who doesn't have diabetic retinopathy at this point of time, the system will be able to predict what is the future risk of this patient going into advanced stages of diabetic retinopathy in a period of 1 or 2 years, just by looking at the fundus photos. As I said, this again has got a tremendous potential as to understand which are the patients we need to follow more closely, and those that can be seen at a much larger interval. AI applications are growing in ophthalmology. As I said, refractive error prediction, identification of other retinal lesions, not only diabetic retinopathy prediction, AMD progression prediction, and even in anterior segment for dry eye diagnosis using smart intraocular lenses, and more importantly, in glaucoma diagnosis. But beyond ophthalmology, it's seen with various studies that the AI is able to predict the sex or the gender of the patient. I mean, we don't know. The human eye can never do this, but there is something that the algorithm is able to predict with almost 97% accuracy, whether this person is a male or a female. Age of the patient can be predicted to almost 67% accuracy. Predicting the cardiovascular risk factor for a 5-year period, like this is something very, very interesting, has got a large potential, but of course needs a lot of longitudinal data to be validated to ensure that this can be relied upon to understand how we can predict the cardiovascular risk factor just by looking at a fundus photo. So there are various other systemic diseases that our retinal fundus can show the doctors, as an anemia can be predicted, and we detected the amount of HbA1c they are able to predict based on just looking at the fundus photos and various other stuff. So there's been a lot of interest in AI, as you can see the growing number of publications in ophthalmology just using AI tools. There's also a large potential for AI in primary care settings, where any person staying in a remote location can use these AI-based tools to triage the patients, and those who really need care can be referred to the ophthalmologist. And only those patients who need the doctor consultation, so that the doctor's time is much saved from screening, rather they'll be treating who actually need care. So AI will soon be definitely used in many aspects of medicine, not only in diagnosis, but also in the prediction of disease and in overall to improve treatment outcomes. I'm sure we'll all see this people think that this could replace, there is no way this is going to replace, but it's only going to augment our treatment outcomes over a period of time. I'm sure we'll see a lot of these tools coming into our practice soon. So thank you again for this opportunity to be here. Thank you.
Thank you so much, sir, for that beautiful glimpse into the future, and also dwelling on literature and giving us practical examples of how we can use it in so many diseases. Of course, you gave the example of diabetic retinopathy and showed us where else it can be explored. Thank you very much. We're shifting gears now. Our next speaker is a scientist, again, very well known. Dr. Shubhabrata Chakrabarti is the Associate Director of Research at LVP in Hyderabad. He is a geneticist, and his area of specialization is genetic biology. And today he's just going to talk to us exactly about that. Ocular genomics, what are the current trends and the future perspectives? Dr. Chakrabarti, over to you, please.
Yeah, thanks, Dr. Vinekar. Can I start sharing the screen?
Yes, please.
So at the outset, I would like to thank Dr. Ajit Babu and Santosh both for the invitation. And obviously, it has been a very fantastic conference over the last 2 days, which I think has been alluded to by all the speakers and attendees. As Anand mentioned, that I would talk more about the current trends and future prospect, because ocular genomics as such has had a very huge leap in terms of their contributions to disease biology, both in terms of disease diagnostics and therapy. So at the start, let me just pose this question: why we do ocular genomics? One, the very fundamental thing that would be necessary for a clinician is to assess the risk. What are the chances of recurrence? If I know a disease has a genetic predisposition, what are the chances that it's going to recur in the same family of relatives? The second thing is disease prediction. Can we do a very thorough predictive testing? And this is where not only the genetic assessment, the clinical assessment of the deep assessment of the phenotype comes into question. We just heard Dr. Vishali Gupta give an excellent narrative about what are the indicators as to how one goes in for deep phenotyping of a condition. And having done the deep phenotyping and a comprehensive genetic assessment, one needs to draw a genotype-phenotype correlation. And at this point, I may say that genotype-phenotype correlation is not done on a single patient. It is done on a cohort of patients with a similar disease or with a similar phenotype. And then if a genotype-phenotype correlation is established, then similar genetic changes occurring on similar conditions can be easily understood on it for its role in the disease pathogenesis. Last but not the least, in most of the conditions, we do not have a defined therapy. So counseling plays a major role, not only in individuals and in families, but at the same time, the counseling has to be based on the merits of the psychological determinants as well as the cultural assessment of the individual's background. So that is where the genetic counselors come into picture and their role becomes imperative. Taking all of this into consideration, and if everything kind of falls in place, where you have a proper assessment, a proper correlation, the patients are counseled, one can then take into account of devising novel, reliable, and simple molecular diagnostics that can predict the disease ahead of a time and can progress for future therapy. So in an ideal situation, the whole area of precision medicine basically looks into a patient entering into a clinic and being clinically assessed based on the family history, the risk factors, and there are multiple questionnaires with all the facets of clinical imaging. And there is a risk assessment, but parallelly, there is a biological assessment based on the biological material of the sample. And there are multiple ways in which one can kind of understand if there is a biological predisposition and then correlate that to accurately establish the risk of the patient. And that goes in for a personalized treatment or a personalized therapy. Coming into the context of retinal dystrophies, there are multiple number of genes that have been mapped over the years, and this is starting all the way from the early 80s to the current scenario. We have more than 300 genes that are mapped, and of which almost 250 or so are characterized. When I say characterized, that means we know what the functions of those individual genes are. And that is what makes a disease very heterogeneous, both in terms of clinical manifestation as well as in terms of genetic manifestations. And the correlation becomes of utmost importance prior to initiating any form of diagnosis or therapy. So if a clinical presentation is suggestive of a genetic conditions, now the earlier understanding was of a single genes causing disease. So one would document the history, the clinical parameters, and go in for understanding if there are changes within the single gene, which we technically call as mutations. If there are multiple genes, nowadays there are other modalities of the deep sequencing or the next generation sequencing, where one usually can run a multiple number of genes in one panel and then get an answer if any of the genes are involved. In cases where there are multiple non-specific concerns, or if there are other forms of disability, such as intellectual disability associated with that, and there are no defined genes, one then goes in for fishing a needle in a haystack using the format of a whole genome or a whole exome sequence. The whole genome is the entire genome of an individual within a dividing cell, which consists of 3.06 billion bases, and a whole exome is only the coding region, which is hardly 2% of that entire genome, which are responsible for certain genes. And that is where one tries to kind of get some answers pertaining to disease pathogenesis. But as I go forward, I would just show you that even those are not comprehensive enough. So having understood all those genes, what one needs to understand is based on the inheritance pattern, whether it is a recessive disease where parents are carriers, the disease occurs in children because each of them kind of transmits one of their alleles to, or one of their portion of the genetic defect to the child. And since the child gets both the copies, they manifest the disease. Or it could be something like, which is X-linked, which is transmitted only from males, or it could be autosomal dominant. It could across generations. It would not skip any generations, but would affect individuals in every generation. What is challenging is in scenarios like this, where disease is kind of sporadic, you do not have a genetic etiology, an underlying etiology in the parents, and that is where one needs to use a multi-tier approach, a multi-omics approach, as we call these days, and particularly in ocular cancers, for instance. In the previous session, Kostav, I think, alluded to some of this, that in cases where there are mosaics, or in cases where mutations are acquired, as in retinoblastoma, like one of the mutation is a germline, which is kind of transmitted from the parent, but the other is an acquired mutation, and that is where the somatic mutations, as we call it, creates a very challenging situation to understand the underlying etiology. So in terms of those alleles, what we are trying to understand, or what we try to understand over these periods where the rare alleles causing a disease, a Mendelian disease, as I showed you in the upper panel of the pedigree, where the mutation segregates from the previous generation to the next generation. And these are rare alleles which have a very large effect because you do not find them in the populations, meaning thereby that their frequency is very rare in the population, but the effects are very high. But with the advent of next generation sequencing technologies, we have found that there are large number of variants in association or in alongside the rare alleles, and that might be causing the disease. In some certain cases, in diseases which are age-related or age-related diseases like AMD, for instance, we do not find really rare alleles or mutations, but these are variants of various effects. It could be intermediate effects, it could be very low effect, but they are very common in the population, and it is a challenge to kind of dissect those signatures that precisely define a disease. And now with the advent of sequencing technology, we have sequencings under various platforms, various chemistries. And if you see the time that has come down significantly, time per run, if you come from the older technologies to the newer technologies, and the cost also has come down significantly. So in understanding next generation sequencing, because that's one of the things that many of the clinicians do send their samples for sequencing. They are interested in understanding the whole profile of the genetic makeup of the individual. So one of the things that one needs to be aware is about the panel, whether you are doing a whole exome, that is all the genes in the genome, or you are doing the entire genome itself, or you are doing selected individuals. For instance, I showed that in RP or in retinal dystrophies, you have close to 250 genes that are characterized. So one could actually ideally design a panel of those 250 genes, and that could be used for very rapid screening. And then there are technical issues of constructing those libraries, preparing the templates. I'll not go into those details and analyzing the sequences. But what I'll definitely go into is about designing the panel. So once a panel is designed, even if it is a whole exome or a targeted exome, one needs to know if your genes are adequately covered. For instance, I'll just give an example. These are a list of genes within a panel, and these are the regions that are covered. But what is important is what is uncovered, which is not covered under that. Because when genes are multiplexed into one single tube and we kind of analyze, we kind of amplify them with the primers, which are and other stretches of DNA, there are various such primers which might compete with each other or which might have offset binding, and that might kind of be detrimental towards amplification of that portion of the gene. For instance, RP-GRIP1, one of the genes again in retinitis pigmentosa, like in a panel, we see that it's not covered adequately like the other genes, which are almost 100 or close to 100. It's around 99.69. That is not important. What is important is how many bases within that gene are left out. And if there are mutations within that gene, one would basically lose out. So, and then the other thing is to do a whole exome sequencing, where one can basically kind of screen a whole exome and then find out what are the other genes. I'll not go into the details. There are advantages of filtering those. But what is important is one needs to identify the functions of those genes. And if these genes have a biological underpinning, they would also be involved in functions. And these are basically done by doing in vivo. That is, you basically knock out genes in animal models and then see the effect. You see about expressions of those genes. Again, remove the condition and see whether the expressions change, and then try to do a correlation. Like, for instance, in one of those cases, doing certain ERG-based techniques and then finding out. This is one of our recent papers that is coming out in Nature Communications later this month. And so these are also used for kind of segregating individuals who would respond to a drug as opposed to those who would be non-responders, and providing risk-specified treatment. And I'll take the last minute just to kind of explain that even in retinitis pigmentosa, with those standard techniques, one can understand only about 2/3 of the condition, even in a very large cases, a large cohort that was analyzed using multiple techniques. As you can see, more than 30% cases are still unanalyzed because there are changes, epigenetic changes and other things that are within the genome, and that causes, creates problems of understanding unless one does a comprehensive analysis. And so it is essential to basically identify what are the gaps that are involved and what are the cellular and molecular mechanisms before undertaking therapy. And since time is up, I would not go into those details, but I just make one last point that there has been various therapeutic measures, like, for instance, we know about the Lux-Turner, which was introduced, and then we have the optogenetic therapy, again, where there are evidences of partial recovery. And in kind of taking these forwards, one needs to understand how clinical translations can be achieved based on understanding the disease pathogenesis, and one needs to actually kind of use their discretions towards generating actionable results. And genetic testing should be advised only if there is a strong correlation. Thank you.
Thank you very much for simplifying a very difficult topic, especially for us clinicians, and also giving hope that this basic research has now gone from the bench to the bedside. And as you call it, personalized or bespoke medicine, I think we're all very excited to implement this research in our daily practice.
Thank you.
Can I ask Vaishali to introduce Anand? Vaishali.
Of course, it's a pleasure introducing Anand. Everybody knows Anand, like he's the ROP star of India, and it's pleasure. So I think Anand is going to talk about ROP and other pediatric diseases. What are the practical aspects? And he's the best in ROP.
Thank you, ma'am, and thank you, Ajit sir and Dr. Santosh sir for this kind invitation, and of course, the organizers of Telangana Ophthalmic Society. I'm going to speak about the practical aspects. So I'm going really mostly into general ophthalmologist or retina specialists, how we can take from this. When we were screening babies for ROP, we found that about 7% of them had other pediatric retinal conditions. And you can see that in just a cohort of about 1,400 babies, we even saw one retinoblastoma. We saw cherry red spots. We saw all kinds of conditions. When you look, on the other hand, as term babies, in this study of 1,000 babies, if we correlate that, if we extrapolate that to the Indian population, anywhere between 50,000 to 200,000 babies may have all these conditions in the country annually. So I think we must wake up to the fact that there are common pediatric retinal conditions that we may all encounter in our practice. And what are the easy practical aspects? So this FEVR versus PFVS is something that's often asked. And we all expect that when we think of FEVR, we look at a falciform fold, but it comes in different phenotypes, including with a lot of dysplasia. It can come with exudation. It can look like coats. And often, if it is a unilateral FEVR, it can be confused with PFVS. So in PFVS, the first thing is that it's a smaller globe. Cataract is more a prominent thing. And if you can depress and look at the pars plana region, it will be hypodeveloped compared to an FEVR case. So these are some of the more practical things that we can look at. Since anti-VEGF in not just ROP, but other pediatric retinal conditions also being used, I just wanted to use this case to highlight that even months after an injection, if you look at the baby clinically, and of course, if you have an angiogram, sometimes there can be very active florid NVE and incomplete treatment. And so unless you go to the bottom of this case and complete the treatment, the disease is not going to die away, and we're going to continue to have all the problems of this disease. A cherry red spot, again, is a very common occurrence, especially with pediatricians looking out for it, and of course us. And it's important to understand its systemic significance. This child had a storage disorder, and it's important, even if the pediatrician hasn't suspected it, to send the baby back. In this case report, a very, very small perivasculitis that looked possibly fungal prompted us to send back the baby to the neonatologist. And lo and behold, this baby had candida in the urine, a perinephric abscess around the kidney, and it was treated very successfully with systemic amphotericin and prevented perhaps even loss of life. Systemic signs is something else. Sometimes you look at the eye and you have to diagnose a systemic disease, and sometimes it's vice versa. So if you see, for example, these hypopigmented patches, look into the eye. And if you've looked into the eye and you see a hamartoma or an astrocytoma, look at the whole body. So in this case, some of these lesions can be so small or so indistinct that you might need to take the help of imaging. In this case, we use the FA, we use the OCT to show you that some lesions are not even picked up on the angiogram, but can be picked up subtly on the OCT as well. And the important thing is, of course, you co-manage these cases with the treating pediatrician. A combined artery or just a single artery or a vein occlusion in a child is not that common. If you see something like this, a bilateral, that to a combined artery and a vein, and this child came to us at a PL hand motion vision, and clearly because of the sparing of the cilio-retinal artery distribution, this child eventually became 6/12. But the important thing was, having suspected a systemic etiology causing it, this child was referred back and ended up having a nephrotic syndrome, which had gone into an exacerbation. So treating this can be life-saving. This was a case referred to us by a dermatologist, and of course we know that the diagnosis should be incontinenta pigmenti. And although one eye had gone into a untreatable retinal detachment, we were able to save the other eye because we detected the neovascularization and treated it successfully. Now moving on to retinopathy of prematurity, I'm going to only talk about the practical aspects because this audience is already very learned on the basic parts. When you look at aggressive posterior ROP, and I'm going to end with how this terminology has changed in the new classification, then one must not look for the standard ridge and extraretinal fibrovascular proliferation, because these diseases can look just like immature retina with a lot of plus disease. But more typically in our setting, we see these blood vessels having crossed not just the posterior part of zone 1, but sometimes even going to zone 2, and that is still an aggressive ROP. What we look for here is the capillary non-perfusion. We look at the loops, and these loops, unless you look at them clinically and you realize that they are bald without the CNP, can be easily missed. The PGI group reported this new entity called the hybrid ROP, where you see not just aggressive ROP in some quadrants, but you actually see the classical ROP in the other quadrants. And these don't do as well with treatment, so it's important to treat and prognosticate. The most practical aspects of ROP screening, we take this from the national guidelines. It's no longer 1,500 grams like they do it in the West, but it's 2 kilos, and it's less than 34 weeks. And a legal caveat would be never delay the screening more than 30 days of life. So even before the child is a month, one must do the screening. And in fact, now the guidelines suggest to do the first screening before discharge of the baby. That's the best way you can get this baby without missing on the screening. And don't terminate screening until at least the baby crosses the 40th postmenstrual age, because until then, normal vascularization is not even expected, physiologically speaking. The ideal dilator drops, the Oropen Plus by the Orolab group, unfortunately went into a fixed dose ban. So today around the country, we find the other drop available with this combination listed below with phenylephrine and tropicamide, Tropac P semi, which is again very effective and more easily available. Tunica vasculosa lentis is something that even general ophthalmologists and sometimes pediatricians see. And the importance here is that you don't need to go into doing anti-VEGF therapy just because you see a TVL. If you just are patient and do a digital ocular massage with your depressor, just as though you are going to laser, a lot of them actually dilate. Documentation in ROP is becoming extremely important, especially with the medico-legal scenario. We've had about 9 cases in the country already after 2015 against pediatricians and ophthalmologists. So it's important to share this documentation both with yourself, your team, and the pediatrician. So leave a copy in the NICU and make sure what card you give the mother or the family mentions the exact date, time, and venue of the next screening. Of course, if you are doing wide field imaging based screening or telemedicine, then you have an added advantage of storing these images and also their digital information. The national guidelines is something that has come out in 2018. This came out a year after the RBSK, and this is probably what's being used. I just want to highlight this 30 days fact there. Where do you do the screening? Well, if the baby is sick, you can do it in the NICU, and the screenshot on top is taken from the guideline. Or you can do it in your own OPD, as long as you have some sort of basic facility to make sure that these babies are taken care of in the unlikely event of an adverse systemic event. When you screen a baby, you can come up with only 3 outcomes. Either this baby is mature, which means that the blood vessels have reached the ora, or it has some disease or immaturity for which you need to follow up, or it needs treatment. So it's actually fairly simple when you break it down. And India is probably the first country to actually allow wide field imaging as an alternative method of ROP screening. And not just that, it can be done by non-doctors or non-ophthalmologists, and you can train technicians or nurses even to do it. For those who don't have the cameras, well, indirect ophthalmoscopy is still very, very effective. Always face the quadrant in which you want to screen, and either you turn around the table or you get the baby to be rotated so that you don't miss any of the peripheral disease. diseases. And well, one important thing that we've learned from neonatal nurses is how you wrap a baby. Always separate their two hands, especially if, of course, this amount of elaborate wrapping is required only when you're doing treatment, so that their hands are not together in the same fold, because then they get very feisty and they're able to come out of that wrap, making it difficult for everybody. The guidelines for treatment are very well known now. They're almost 18, 20 years old. So it's the early treatment. So the only exception you treat when it does not have plus disease is if there is stage 3 in zone 1. Otherwise, plus disease requirement is a very, very important prerequisite. Just last month, the International Classification of ROP came out with its third edition. And this is for the first time we've had co-authors outside Europe and the United States, and we even have 2 from India. And that's really important because this classification now addresses what are the spectrum of the disease that we see in countries like ours and other low middle income country groups. So this is actually the table right at the beginning of the article that tells us what's new in this classification vis-a-vis the 2 previous ones, but I'm going to just highlight what is relevant to us. So as I was mentioning in the first case, aggressive posterior ROP has now been replaced. That term is no longer to be used. We now simply call it aggressive ROP, and that's because aggressive ROP need not be posterior. And there is a spectrum now. Rather than go over these definitions, I'm going to show you the images from the text itself. But firstly, the big dilemma of when to call something plus disease and pre-plus disease, a term that we got in 2005 classification, is fortunately being slowly done away with by the acceptance that plus is now a spectrum. So from what looks completely normal to what looks completely abnormal, there is a spectrum in between, and this article actually addresses that. And now coming to the aggressive ROP, some of these images are from us, from our country, and from similar graphic nations. You can see, look at how they look in terms of the complete obliteration of the blood vessels and how the capillary non-perfusions are there. The blood vessels look as though they've gone into zone 2A, but actually the CNP areas are in zone 1. And then a new aspect that has been added into this classification is reactivation and recurrences after anti-VEGF. Just want to draw your attention to image B right on top. So you can see sort of 2 lines. So the first line, more posterior, is where the primary disease was, and the more anterior one is where the reactivation will happen. So we have to be now attuned to looking at these newer things that we'll see by the way we are treating these babies. I'm going to end with the COVID-19 IROP guidelines. The Indian ROP Society came out with these guidelines and published them online on our website, and now it's a peer review publication. I'm just going to summarize that. I mean, of course, you're welcome to look at the website now. Follow-up has changed. We don't, especially in the pandemic where we are not sure of their coming back on time. One can delay the number of visits or reduce the frequency of visits based on what we see. And in treatment, if you look at the 4th row, the less than type 1 ROP. So when can you lower the threshold for treatment? That's exactly what we've addressed here. So even if there is some sort of a pre-plus, or if there's stage 3 with early plus or no plus, but there is a poor media, poor pupillary dilatation, and you're unsure whether the child will come back again, you're not wrong in treating this baby a little early, because sometimes travel itself becomes difficult in the pandemic. But what's really important here is to document the fact that you have treated outside the ETROP guidelines because of the pandemic. Thank you very much. And once again, thank you to the organizers for this opportunity. So I think
we'll take over.
Right. We'll move on to our next speaker before we take the Q&A session. Dr. Pramod Bende, Senior Retina Specialist and Head of the Retina Services in Shankar Nethralaya, Chennai, is going to talk about diabetic vitrectomy, the changing trends. Over to you, sir.
See my slides?
Yes, sir, they're visible.
Yes.
Perfect.
Good evening, everybody. And at outset, let me thank Dr. Ajit Babu and Dr. Santosh for having me here, and obviously thanks to Telangana Ophthalmology Society. So Dr. Ajit wanted me to talk about something more like a surgical here. So though with the time, goal for the vitrectomy for PDR has not changed, basically to remove the media opacity, to relieve the anterior-posterior retraction and tangential traction, and the stabilize diabetic neovascular process by removal of vitreous scaffold, surface proliferation, and laser to ischemic retina. What we are looking at now with the changing trends in the technology, we have small gauge technology with the wall cannulas, newer cutters with a high speed bevel tip, port optimization, wide angle visualization, improved illumination, pre-op and wage-ups, and new things coming up as a 3D, intra-op OCT, and robotic surgery with time. So what it leads to, leading to increased safety, and then hence more complicated can be taken up for the surgery. Just we discuss few things one by one. Now, port optimization and variable duty cycle, we have placement of the port nearer to the end of the probe, and which allows working closer to the retina with a better control and true versatility, where probe can be transformed into multifunction instruments like scissor, forceps, or a peak, and that is what you see here. You can see the cutter is being used as a forceps in this video. Just use as a suction to grip the membrane, and then you lift it up and slowly peel it from the retinal surface. And once you have a nail you encounter, you can just cut those, just activating the cutting force. As against when you see the next video here, what you are seeing is it is using it as something like a peak. One hand is holding the forceps is holding the membrane up, and without, this is a blunt dissection using a cutter itself, acting as a peak here to lift the membrane up. So things are becoming much easier. We don't need many instruments nowadays. A cutter can just work magics here. This is another case showing port optimization again. So just to compare this video, what you see here, both are actually 125 gauge. One is showing a, what you are seeing here is scissor being used, and parallelly cutter is using exactly the same way. So now what you do here, when you use a cutter as a scissor, you cut down, reduce your cutting rate to almost 100 cuts per minute. And as you see here, and with the shaving mode, you can see exactly similar videos. One is using scissor and other one using cutter. So you practically eliminate the need of the scissors with a newer cutters here. Coming to wide angle visualizing system, gives the panoramic view even though small through the small pupil and hazy media. And most important, you have a better view during fluid exchange, both in phakic and pseudophakic eyes, and obviously has a great depth of the field. The commonly used systems are Biome and ReSight. Both are non-contact, but we have other contact lens system also being used in India everywhere. And this is just to show this clip. As you see, the both eyes having a small pupil. This is a pseudophakic eye, and see almost the entire retina you can view here. And the other one in a post-FG scenario. And as you look at it here, again, the entire view of the fundus without much reflexes. So your visibility is critical when you're dealing with these VR cases. This is another comparison between a lander system and your ReSight. As you see the view, what you get to ReSight, this is showing a segmentation. This is a classical technique. And as against, you see the view with the ReSight, it's really a wonderful depth and a wide view. Coming to illumination, obviously with MIVS and wide angle visualization system, we require much brighter illumination source than what conventionally we used to have as a halogen light. So xenon and LED is filling this gap. Also, most important is this filter out the blue light, which allows the surgeon to operate much longer without having a risk of retinal phototoxicity. So also we have improved fiber optics, which has reduced the transmission losses, offering superior illumination, and actually effective illumination what you use is much lower now. And we have multiple light probes like as a chandelier, as a wide angle light, like a bullet light, and which gives a hands-free viewing and to have a true bimanual surgery. This is just showing one of those cases here. You have chandelier, we are putting an infratemporal quadrant, and then you can, depending on amount of where you would like to dissect, you can have either is a 12 o'clock or any other quadrant you choose, so that you can eliminate the shadow, or you can use a multifunction like here you have a 25 gauge illumination combined with infusion and gives an excellent view illumination for your bimanual dissection. And as you see here inside, illumination is adequate enough for your surgery. Anti-VEGF has changed the way we practice and operate the diabetic cases. The purpose is to reduce the vascularity of the visual vascularity of the fluorid fibrovascular proliferation. And with reduced vascularity, probably makes the surgery technically much easier. Fibrovascular proliferation would readily separate from the retina. There's a less intra-op bleeding, so fewer endodiathermy, so reduce post-op inflammation, better intra-op visualization, so decrease overall surgery time, and because of few tool exchanges, so reduce the risk of sclerotomy-related iatrogenic problem as well. And you have a more complete removal of fibrovascular tissues, so reduce the risk of reproliferation and recurrent post-operative hemorrhages. But what you need to understand is anti-VEGFs cause rapid regression of fibrovascular proliferation after injection, but reactivation can occur anytime after 2 weeks. So you need to choose the window when you want to inject anti-VEGFs for surgery, and preferably the window should be somewhere between 3 to 10 days. And obviously you need to have systemic clearance before injecting, because all these diabetes can have multiple systemic issues. And if necessary, and by some reason, if things get delayed, surgery get postponed, probably you may have to re-inject. And these are few pictures showing pre-Avastin and post-Avastin reduced vascularity and post-vitrectomy 6 weeks later, one eye and the second eye of this patient, things work out much easier, surgery become, like our life become much easier. Coming to just to have a combination of everything, what I discuss is ultra high speed cutter with anti-VEGF, with your wide angle illumination and visualization, as you see here. And this is 10,000 bevel ports, sorry. As you see here, practically no movement of the retina. You imagine here, I'm shaving the membrane over the surface of the retina, and the cutter moves so smoothly, and because of being bevel, you have enough gap, cleavage plane to find. And as the cutter moves over the surface of retina, you look at here, practically no movement of the retina. Just you clean shaving, it goes on. Okay? And that's a beauty we are having with the bevel probe. And of course, you need to modify, you use a shave mode here, you can reduce the cut rate, but what is using mainly here, advantage here is a bevel tip, and port is close to the tip. As against here, another case is a young diabetic, where I use a bimanual illumination source and a bimanual, using one hand using a forceps and other eye using cutter as a scissor. Each individual attachment can be identified, and you can just trim or cut, or as you see here, when you lift the membrane a little bit up, you angle it in such a way that you can see the cleavage plane very clearly, and you can keep on cutting those fibrovascular attachments, separating the membrane, almost practically bloodless surgery, because patient did receive anti-VEGF before surgery. And this is the same patient having both eyes I operated. This is a post-op picture at 2 months, showing excellent result. So yes, cutter is used good one, but not everywhere cutter can be used. And this is a case where having a combined detachment, and obviously retina is highly mobile, and sometimes cutter can have not that good control, rather I would say. So scissors definitely have a better control here in this scenario. So again, post anti-VEGF, but still it bleed. But what you see is definitely you get a much better control while using scissors here and bimanual technique rather than using cutter. So scissors still have a role to play. Not everything you can manage with the cutter. Just to conclude, we are looking at a newer developments as a further refinement of a cutter, scissors, light sources, and laser probes. We are having a curved probes now available. Small gauge multifunction instruments, which I showed you about in combined illumination and in infusion, and few more are coming up. Intra-op OCT, having a better identification of the tissue planes, heads up 3D surgeries, and obviously robotic vitrectomy. So thank you very much for patient hearing. And this is what 3D video, just converted to 2D. I can still see, make out excellent quality of picture and having a depth perception here. Thank you once again for Telangana Ophthalmic Society for giving me this opportunity. Thank you.
Thank you so much, sir. Those were beautiful videos and great points, well illustrated. I'm sure there'll be questions at the end. And you ended with an example of 3D converted to 2D, and that takes us to the correct platform to introduce our final speaker for this session, Dr. Prashant Bavankule. He's a friend. He's going to speak to us on the 3D ocular surgery, the need of the hour. Over to you, Dr. Prashant.
Thank you, Dr. Anand. I will be sharing my screen. Yeah. So at the outset, I would thank Telangana Ophthalmic Society, Dr. Babu, and Dr. Santosh for this wonderful opportunity. Well, is it fashionable just to sit like this on a screen and operate, or does this system offer us much more? Let us go through this presentation. Dr. Pramod Bhende has already introduced us about the 3D, that is digitally. Exactly, this system offers about 24 to 40% more magnification than what an highest magnification a digital microscope or a routine microscope, analog microscope can offer. Now look at the advantage. As a vitreoretinal surgeon, have we ever operated at such a high magnification with an analog microscope? No. Why? Basically, because in this magnification, you would be compromising on the field as well as the depth, which was always a challenge with high mag. And here you can see, you can discern all the tissue structures, membranes, and the ILM so well under such high magnification. Another example why high magnification can definitely be a blessing. Here I am doing a base excision. You can see the small vitreous fibrils which I am cutting through with the help of this particular thing. Here you can actually see the fibrils. This is base excision being done directly under the microscope view at such a phenomenal magnification where you are seeing you can appreciate each vitreous fibril. The other advantage is about the depth. It offers 11 to 42% better depth resolution than an analog microscope. Now, this is a tabletop TRD, which we have seen beautiful videos with Dr. Bhende. Any such a tabletop TRDs will always give a bit of tension to any surgeon, but look at the ease with which I'm moving my vitreous cutter. This is an unedited video, and my video cutter is moving at a speed which is unedited, which speaks about the confidence, the depth which it allows me at the speed, and that is why the speed with which I am operating. And at the end of the surgery, yes, you can see the beautiful part of it, surgery being completed without any iatrogenic problem. The other basic advantage is it offers a field of view which is 5 times better than the routine field of view. Now look at this, another case of diabetic retinopathy. The whole attachment of vitreous to the membranes, to the retina, that is the whole pathoanatomy, can be visualized in a single field of view, thereby giving us better insight into how we should operate, when should we operate, where should we cut a membrane, how to delimit a vitreous from the membranes and all those things. And that's why you can get such a predictable results in such cases, in such complicated cases. Another case of a 270-degree GRT where you have to see an unrolling of a flap with the help of a PFCL. Well, I have identified the disc and now I'm putting a PFCL bubble. Could you ever see such a beautiful unfurling with a routine analog microscope? No, because it always compromised on the field of the view. This is an anti-segment case where we are supposed to do an iris repair. After completing the phaco, I am doing an iris repair, 4th row not being done. In such procedures, complicated procedures, you not only need a magnification, but also you need better field of view to have a simultaneous view of what is happening inside the eye as well as in the periphery to help you in doing such complicated surgery. Color filters are definitely another blessings. When you have a severe choroidal sclerosis, well, you cannot many a times, in spite of staining, see the ILM so well. So here you have a filter where you can see the ILM and other tissue structures better defined, but thereby permitting you the ease of membrane peeling. Yes, red eyes in a digital, red color definitely dazzles your eye in a digital vision. And here is what you do with a red free filter, then you can overcome this particular difficulty. Now, this is a case of a capsular access being done. I have stained the capsule, but somehow I'm not able to see so well. I have changed to filters and now see the visibility. of the stained capsule. These are the definite advantages in posterior as well as anterior segment systems about the color filters. And all these advantages you get at an illumination which is 1/10 of the microscope, thereby reducing the chances of phototoxicity and less corneal drying because of halogen. Yes, ergonomics advantages, well, we are aware of, as well as the advantage it offers to the postgraduates. They can also see the same image what a surgeon is perceiving. Now, let me share with you few of the VR's typical cases. This is a case of a more than 180-degree giant retinal tear, and you can see I have done a complete vitrectomy, ILM peeling being attempted, then a PFCL laser, and a beautiful completion. Such complicated cases appear so simple with such a big field of view and good magnification. Well, this is a case of a myopic foveoschisis, where because of the choroidal sclerosis, well, in spite of staining an ILM, it is difficult to pursue an ILM. So after staining and using a long forceps, dog forceps, which is 24 millimeter in length, I'm able to visualize the ILM. And even in such difficult cases with proper filters, proper system, I could visualize and I could do a complete remover of ILM peel. In a case of, well, even in cases of ROP nowadays, we use this particular system. This is a stage 4 ROP, stage 4B ROP, where I'm doing a vitrectomy, and here I'm doing a bimanual surgery as well under this system. And look at the magnification which it is allowing, and look at the architecture of the tissues, retinal tissues, as well as the fibrovascular, where you can easily discern the difference between the retina and the fibrous tissue. Well, and this is another case. So this is another case of a ROP where I'm sharing with you. We have done more than 10 to 12 cases now on this particular system. And you can see even such complicated cases like ROP, we do not hesitate and we just go ahead with any routine procedures on this particular system. Well, another case of ROP. Well, as a retina surgeon, if you are also having an anterior segment sharing surgeon sharing your OT, does this system come in the way of anterior segment? No. This our article which got published in IGO says about the use of 3D system beyond vitreous, even anterior segment procedure. And this was the aim where we studied, and what we concluded was there 3D system or a digital system, anatomical and physiological results are similar in both group. It is non-inferior to microscope. In regards to safety, it is definitely as safe as microscope. Surgical time is definitely more during the learning phase. Time lag and learning struggle is more appreciated only during learning phase. Field of view, depth of perception, and color contrast is definitely better pursued by a surgeon in 3D surgery, besides postural comfort and as an educational tool. These are some of the challenging anterior segment procedures which I would share with you. This is a case of a siderotic cataract with the intraocular foreign body. Such a stained cornea, it was difficult for us to view. Well, proper use of filters, proper use of light, and the illumination, only 1/10 of the illumination you can see in the absence of a glow. Here I am doing a phacoemulsification through a hazy cornea. And after completing the phacoemulsification, a vitreous procedure done and the foreign body was removed. This is the beauty of such systems where visualization. Now this is cataract nigra. You can appreciate over here, such a difficult no glow. Well, again, the use of filters and other systems, well, you can manage even a grade 5 cataract. Means what the intention of showing nigra is that even the most complicated cataracts we do on this system. Well, this is another challenging case. This is a albinotic nano-ophthalmic, a patient having grade 4 cataract. The challenge here is that the red color augments and it bites your eyes when you are. So using a filter, you can tone down the red color which comes in the way during the surgery. Other challenge was that the anterior chamber was very shallow, being a non-ophthalmic eye. It was less than 2.5 millimeter. But in such a big system, when you see a screen as big as 40 inches or more than that, the whole eye appears so big that the anterior chamber depth never became a problem to us, and we could do an uneventful cataract surgery in such a shallow chamber with such a red albinotic eye. Well, even such complicated cases with a capsular fibrosis can be managed. This is a case of a rubiosis iridis with a complicated cataract, where the cornea was edematous. We had to scrape, we had to use the iris hooks to visualize, and after that the cataract surgery was almost similar and we could complete the procedure uneventfully. This is another case of 200-degree subluxation where we did phacoemulsification with CTR. Well, you can see after completing the phacoemulsification, capsular excess, phaco being done, then CTR, we have introduced the CTR after removing the cortex and the lens was put. Here is the introduction of CTR and then the placement of the intraocular lens. Well, this is another case of a subluxation where I would just run through it. Even the premium cases like trifocals and all, we do routinely under this particular. So even such complicated, demanding cases, we use this system as a routine procedure as a sub instead of microscope in one of our theaters. Well, this is another case of a traumatic cataract with a iris tissue loss with a corneal opacity. Another challenging case. This was, we did a capsulorhexis, we did put a lens, and after putting the lens through this hazy cornea, we decided to do the iris repair, and this is the reconstruction of the pupil. This is cataract with combined RT. Well, this system allows you very easy conversion from moving from posterior segment. Last but one slide. And so even in the absence of a glow, I've done a phacoemulsification cataract and then doing a.
Prashant, you have 2 minutes.
Yes, sir, I'm winding up. This is my last video. And this is the completion of the procedure. Well, we can use it in other procedures like pterygium, squints, my other colleagues use, even Ahmed glaucoma wall, trabeculectomies, in scleral buckles. So to summarize, 3D digital surgery is here to replace conventional microscope because of the high magnification associated with enhanced depth imaging, better peripheral acuity, all at low illumination, and also the advantages of color and light mapping. So if you see better, you are going to deliver better. And so it is up to you to now decide whether you would like to look at the moon with a bare eyes or with a simple telescope in the era where you have reflecting and refracting telescopes, which can help you picking up an insect on the surface, crawling on the surface of a moon. Thank you.
Thank you, Dr. Prashant. I think before we move on to the Q&A, I'd really request our chairperson and our co-chair to say a few words.
Yeah, overall, this session was planned for listening all the advances as well as some caveats in ocular genomics, especially for the general ophthalmologist, what they need to look for and how they need to approach for the genetic evaluation in common ocular diseases. As well as I asked Pramod for surgical expertise. You have seen his videos. I always amused with the surgical expertise he shows, and he simplifies the things very well. That way, the whole session has come out very well. At the end, Prashant has showed. I asked for posterior segment ingenuity slides, and he said, no, I want to show both anterior and posterior, and he has nicely justified why he has asked, and I thoroughly enjoyed his presentation very well. Thank you, Prashant. And Vishali, in the beginning, I expected her to speak more about the advances, but she nicely pointed out that all advances are not advances. You should be very careful in choosing the advances. So the first question, I think Anand has already put forth to you. But while choosing or even investing your money, what are all the newer advances in retinal imaging would you foresee that they will stay in practice, which are both effective, both economically as well as result oriented?
I think while choosing, basically we still need fluorescein angiogramming, which remains very, very important tool till date. And wide field has a great advantage because it shows you lots of peripheral lesions. Wide field ICG I love, but it will again depend on the type of the practice you are doing. So if you are not looking much into uveitis or into this, I don't think you need ICG just to show you polyps. So I will not invest in ICG if I have less money. And OCT, of course, the different machines offering different things. So that remains the choice. Anand also asked me what would my ultimate dream would be. My ultimate dream would be that if it is able to show me the cellular composition, like if I'm seeing those hyperreflective dots and it shows me these are inflammatory debris out there, or if I'm seeing subretinal deposits and I'm able to see atypical cells sitting there telling me of lymphoma, that would be ultimate. And beyond ultimate would be genotype phenotype correlate, which I don't think would be that simple.
Thank you, ma'am.
We got some question on the chat also. We picked it from the lobby, so you wanna quickly review it. These are from audiences.
We are not able to see the questions. Could you please read them out or just tell us now?
Anand.
Okay.
Shall I read it for you? I think
Yeah. Can you read it out for us? Then we will address that.
I think
Please,
it is.
read out for this speaker whom it is addressed first, and read out the question.
I think this is for Dr. PB. What is your suggested?
That we will wait for his turn. Okay.
Okay.
We are going speaker by speaker. So if any questions are there for Vishali, we are done. Otherwise, we are done with
Question
Vishali.
for Vishali on this chat box.
We can take a common question, and because we got all these speakers with us, let's take one by one and close it.
Yeah.
That's my suggestion. Yeah.
Then let us move on to Kim. Kim has I have listened to his lot of talks on AI, but he moved 2 steps ahead now with a lot of predictions over diabetic retinopathy, AMD, and CVS diseases. Kim, how far the data has really you have means you have been analyzing this on AI for quite some time. How far did you reach in analysis?
No, right now we are only using AI in real time for detection of diabetic retinopathy. We are also working on the University of Oregon for ROP, that's in the validation phase. We're also looking at the study for predicting DR, but it's still a long way to go. Meaning still data is being collected, but that's going to take some time. But the algorithm has been developed, but we are in the process of validating whatever. So it's a longitudinal data that you require, and you need some more time before it can actually come into actual use. Yeah.
You said that there is a possibility of predicting the progression even in patients who do not have diabetic retinopathy.
Yes, exactly. That's the particular validation study we are planning to do now. We are yet to start. So it will predict those patients who have diabetes, and then you subject their fundus photos to the algorithm. It may be able to predict over a period of time, is that patient going to develop advanced stages of diabetic retinopathy or not? But we don't know. It's still in the study phase. It has to go through a lot of validation studies before it can come into actual use.
Anand, do you want to ask any questions to Kim?
Yes, sir. This one, in terms of the, I was trying, when you talked about
already posted the question.
Integrating it into telemedicine, because it's now able to do such a good job in picking up the initial triage. Do you see that years down the line, we will not require reading centers? Will that put a problem in our employment? Will people start losing jobs? Because this is often a question asked.
This is something that with AI in every field of our life, people are questioning whether AI is going to make people lose their jobs. It's like when machines came, computers came, did people lose the job? It is not going to happen like that, but it's just going to better certain things, like, especially when we are talking about grading, the consistency with which the grading is done compared to the human graders is so grossly different. It's consistently the same when you're subjecting an image to grading. And it's also available 24/7. That's another big advantage. But whatever said and done, your question of whether it's going to replace specialists, I don't think so, because specialists are still, what AI can give you is just information. But how you
Not so much replace specialists, sir, but replace graders.
Yeah, graders, yes, definitely it can replace graders, but definitely it will replace the graders. But I'm sure there are other newer things that we will start finding with those graders. Yeah.
Okay, now we will move on to Shubho. Shubho, you
Yeah.
are expert in the field of ocular genomics. There is undoubted, undisputed fact. But what general ophthalmologists look at you is the one is the family, the diseases which are genetic diseases which are running in the family with 3 generations available and all. Now that evaluation is very, very clear. But you talked about the single mutation, the first mutation happening in an individual. How to go about it at a ophthalmologist level?
Yeah. So, as you have seen in retinal dystrophies, over 300 genes are currently mapped and 250 genes characterized. That means each of those 250 genes has some mutation or the other, starting from retinitis pigmentosa to LCA to, all the forms of your retinal dystrophies. So if their mutations are well characterized, that means we know what are the functions of that. And then if that can have an actionable result, like in India, we do not have those regulations, but if in the West, for instance, FDA has very clear regulations that you can undertake genetic testing only under 3 conditions. That is, one, of course, the patient has to be willing and there has to be a kind of a consent. But more importantly, that the lab which is performing it has to have the ability to generate it accurately. And third, it is going to either impact the practice pattern or it is going to kind of do some benevolent thing to the patient. That means you would be able to predict progression, you would be able to predict prognosis, or it would kind of guide you in some forms of therapy. In India, we do not have that. So, for instance, the most of the genetic labs in India, the commercial ones, they are just randomly kind of giving results, but ultimately many of these results are turning out spurious. Number one, because of the fact that we know a single gene doesn't kind of lead to a disease, just maybe mutation in a single gene. It is multiple genes having working in concert, and so they have varying magnitudes of effect. So current understanding or the current way the field is moving is towards understanding the whole scenario in a very comprehensive way. And secondly, I think
As we may take 3 minutes extra for this session. This is the last session, right?
Yeah, but we are up to the time now, so we can close this topic and then we'll move to the next speaker. If you don't mind,
no, in 3 minutes, we will be closing this whole session.
No, sir, we have one more session to go at 5:45.
Yes.
Oh, really?
We got another 6 speakers almost waiting. 3 speakers.
Then I think we'll move on to the next speaker. That is Anand. Anand, quickly comment about the ROP New Year guidelines during COVID.
Yes, sir, I think as I mentioned, it's on the website, and we were trying to simplify when these babies can be screened and when we can treat a little early so that we don't miss these babies. So
mainly in terms of medico-legal problems, how you can avoid by sticking to the means without compromising so much on the guidelines.
Yes, sir. So that's exactly why we made these guidelines, so that there is a medical legal backing on why we choose what we chose to do. And it's loose. Of course, it is based on the ICROP guidelines, but it fine tunes it to say that we can see these babies less frequently, and whom to do that is listed in the guideline, and when we can treat a little earlier.
Okay, thank you, Anand. I think with this we will close the session. Both surgical topics are very well covered by them. And if you have any questions, Anand, for Prashant or Pramod, I think they have very well covered those 2 topics. So we'll thank all the speakers and thank everyone, because Vishali, Kim, Shubho, Anand, Pramod, and Prashant. Thank you for my request because it's very short notice. Though it is webinars, still it requires a lot of effort and preparation. Okay.
Thank you, sir.
Thank you all, and I wish to see you in on site very soon. Virtual is becoming live nowadays.
Thank you, Dr. Ajit.
Thank you very much. Thank you. Thanks, Ajit,
Thank you, Ajit.
for having us here. And Anand, nice to see you
At
again.
least virtually we can
Team,
see each other.
Prashant.
Thank you.
Perfect.
Thank you, Raj. You can
Thank
take
you.
over now.
Thank you. Let's give a round of applause to all the speakers, chairpersons for being so grateful and fruitful to the audience.
Yeah.